you hear me?
Yes.
Okay, good. I'm Dr. Paul Lembury. To remind you that we are starting a new system, GI system. With me, I have my friend over here, Dr. Faisal. Give a big hand to him. He is here to watch me if I'm doing a good job or not. Anyway, we have two PowerPoints today. One PowerPoint I'll complete it. That's in relation to the peritoneum, the basic concept. You know already the peritoneum. We had a gross anatomy lectures already. But I'll be talking to you in a different perspective, embryological perspective, how the peritoneum is organized. You will enjoy that. But at the second part of my PowerPoint will be starting of the GI system in relation to the process, the molecular mechanism, what are the things you will be thinking about it. Just the very basic aspect of the GI development. I'll not complete that PowerPoint. Just a couple of slides I want to show you to emphasize the fact that the GI system is important and you know already a little bit. To my understanding, it's quite a bit you know already that how it is organized. But I'll be talking about the developmental problem associated with the GI tract. But very basic, maybe 6-7 slides I'll be showing you. Okay? So the first slide, first PowerPoint, this one, peritoneum concepts only. This will be associated with the maybe 10 slides, and then we complete that PowerPoint. The next one will be the beginning of the GI system. Is that clear?
Yes.
Okay. With this little preamble, let's start the ball rolling, okay? Now this photograph, this is my hand drawing one, is shown to you 1,000 times. Today is the 1,001.
Yes.
Is that correct? You know A to Z about this thing. And this is basically the early part of the 3 germ layers, you know, the ectoderm, mesoderm, endoderm. Just to orient you a little bit one more time, this is the ectoderm, basically showing you the skin. This ectoderm also has the neural tube and the neural crest. These 3 things should be there anytime you are thinking about the ectoderm. The skin, the neural tube, neural crest. You know it already. Then the second layer is the mesoderm, and therefore it has a 3-part, the paraxial mesoderm. We'll do that in detail in the musculoskeletal system. Intermediate mesoderm, we did it already in relation to the kidney. You know it, the posterior abdominal wall, how it is present over there, the architecture, etc. And then finally the lateral mesoderm, which has 2 parts, which is the somatic, and then splanchnic. Now, I did not go detailing of that, but this time I want to go in slightly in detail because of the fact that if you see my drawing, that the somatic part has 2 parts over here. And similarly, the splanchnic has 2 parts. And I'm going to explain to that what are the 2 parts meaning to you. So when you think about when it is folding, okay, it has to join this one with this one, and this one with this one, okay, to make it as like a ball, or sometimes we often call as a balloon type of structure it will form when it is folding. Is that okay?
Yes.
So these 2 parts, let's do it right now. What are the 2 parts we are talking about? Then this part will be more understood when the system is folding. Like you can see, this is from the book. You see there's 2 parts there, 2 parts over there. This is the same, let me orient you a little bit more. That this is the ectoderm, part over there is the neural tube. This is the notochord, of course, is a part of the mesoderm, so, and it will come over there along with the paraxial mesoderm, intermediate mesoderm, and the lateral mesoderm has the 2 parts, okay? So my diagram, this diagram more or less is the same. But this is a little bit of folding. And I told you ahead of time that we all look like a cylinder, remember when it is folding, okay? And therefore, this is the cylinder I was referring to. Now it's completely folding, The embryo has folded completely. Okay. Now let's see if you can identify the structure. My sincere request to all of you that tonight is your night when you go back and draw this one to understand each and every fragment of this cylinder. Okay? Therefore you can understand. Let's do that one more time. Again, this is the skin. Now the skin has covered the whole place. This is the cross section. This is the posterior part. And this is the anterior part. How do you know it is anterior part? I put a little umbilicus over here. Umbilicus in the front. Okay? Anteriorly placed. So this is the neural tube, another thing posteriorly placed. The dorsal aspect. This is the ventral, this is the dorsal. And this of course neural tube will come in between the paraxial mesoderm later. We'll talk about that later, not now. But trying to understand the different parts, paraxial mesoderm, intermediate mesoderm, lateral mesoderm, again has two parts. This one is the somatic, this one is the splanchnic. Now the somatic part has again the two parts of the somatic part of the lateral mesoderm, right, in my drawing. The outer one gives rise to muscle, anterior abdominal wall muscle. Okay? Some of them come from paraxial mesoderm, but also from the lateral mesoderm. Okay? So think for the time being. I have not gone to the paraxial mesoderm, the detailed musculoskeletal system. But for the time being, this line represents the muscle. This line, the next line is the parietal peritoneum. You heard the name parietal peritoneum from Dr. Olina, right?
Yes.
Okay, very good. So now, if I have a tumor in the abdomen and you want to do a surgery, then you have to go through the skin. So let's see the layers that you will be dissecting. Skin, muscle, parietal peritoneum. These are all supplied either by the dermatome or by the somatic nerve. Not autonomic nerve, somatic nerve. So it is painful. If you don't give me anesthesia, I'll be shouting because I'm getting pain. But once you are over here, this is this splanchnic one, I will not get the pain because it's supplied by the autonomic nerves, you know that. Now let's do the different layers over here. The next layer is the visceral peritoneum, this one. And this one, can anybody tell me what is the next one? Smooth muscle, very good. Give a big hand. Who said that? Very good. Well done. Well done. Smooth muscle. So smooth muscle is coming from the splanchnic part of the lateral mesoderm. So smooth muscle. And then this one is the endoderm. This is the endoderm, right? So now, if you want to come to the, like there is a tumor in the stomach. You want to go to the stomach. So this is the structure. Stomach is over here. So you have to go through all the layers now. Skin, muscle, parietal peritoneum. These are somatic nerve. Then there is a space. Can anybody tell me what is this space called? Intraembryonic coelom, initially they call, but it is the greater sac actually, or abdominal cavity. This is actually the greater sac. Remember the fact we need a little space, always in the little space, either in the chest or in the abdomen. We have the space. And I told you why we need the space. Because very soon you will be hungry, you go to the cafeteria, and then you eat maybe 10 chicken instead of 1. So there should be a space for your 9 chicken coming over here. You will not get pain because all by the autonomic nervous system. So there's a space there we call, very early part we call intraembryonic coelom. You remember that? Intraembryonic coelom. But later it is called the abdominal cavity, or in a very embryological term we call it the greater sac. Mostly greater sac. Okay? And then you come to this layer which is called the visceral peritoneum. And then you have this one, which is the smooth muscle, and then you have the endoderm or the organ. Now when I call the organs, remember endoderm is responsible for the formation of the most of the part of the GI system. I'm talking only the epithelium. Think about now, just correlate yourself, make it very interesting to you. You take a stomach. What are the three parts of the stomach mostly visible? One is the innermost part, which is the epithelium, then is the smooth muscle, then is the visceral peritoneum. And that's what exactly it is. This is the epithelium of the stomach, or maybe it will be the duodenum, or maybe it will be the transverse colon or the ileum or whatever it may be there. But epithelium makes the tube. Epithelium makes the tube. GI tract is a tube. The tube is made of epithelium coming from endoderm. Make it 100% clear. Then it is associated with the smooth muscle and then the visceral peritoneum. Is that clear?
Yes.
So this concept, you may get it more when you draw by yourself. My drawing is 100% correct. And I just beat my own drum. I said, you know that, the $1 million drawing is over here. But I need $1 million from you, drawing. So at night, if you just sit down and draw this thing and try to understand which one is, and make sure that you are correct by looking at this particular photograph, okay? So all the organs are endoderm, so I wrote it over here, and then you can put it. So we look like a cylinder. This is a cross section. Okay? Now, do this thing. Take this layer together. These two layers together, meaning that you have the visceral peritoneum and parietal peritoneum. Take together and just take it out. Can you do that?
Yes.
Just take it out like this and put some air on this. Put air. It will be like a balloon. Yes or no?
Yes.
It looks like a little crescent shape, but if you put lots of air over there, it will be puffed. It will be looking like a balloon. Now, how does it look like then? It will be like this. Here is the parietal peritoneum, is the visceral peritoneum, lots of air over there. Now, where is the endoderm right now? Endoderm is behind the peritoneum. It's all retroperitoneum. All GI organs initially, I'm using the word at the outset, they are all retroperitoneal, meaning behind the peritoneum. And you can see my diagram. If you don't believe me, go this diagram is also behind the peritoneum. Is that okay?
Yes.
Very good. So I go back again, and just to emphasize that this is the lateral view, because you can see the umbilicus is still there. This is anterior, this is posterior. Okay? And the balloon is there, parietal peritoneum, visceral peritoneum. All the organs are retroperitoneal. That's what I wrote it over here. Observe all GI organs were initially retroperitoneal. Make no mistake about that. Now what happens to this, and I wrote it over here, the organs may be stomach, transverse colon, intestine, duodenum, pancreas, and the kidney. Of course, kidney doesn't come from the endoderm, it comes from the intermediate mesoderm. It's a mesodermal structure, right? But most of the other organs are the endoderm. Now what happens is, out of all the organs I indicated over here, some of the organs are very lazy. Like I'm expecting maybe 75 students over here. We have like 55 students. If I count 55 students, what happened to other students? They're still sleeping. They're a little lazy. So some organs are a little lazy. Some organs, they want to go inside the balloon. So what will be the diagram now? Look at my diagram now. Some of these structures, like stomach, transverse colon, intestine, they are very active, including liver. They go inside the balloon. And what do you call that? Intraperitoneal. Very good. Intraperitoneal. And some of the structures, they are lazy, they stay behind, and therefore they are retroperitoneal, like duodenum, pancreas, and the kidney. Although the kidney is not coming from the endoderm, it is a mesodermal structure. But I put it purposely because it's behind the peritoneum. Now, the interesting part is, when it is coming inside the balloon, it takes 2 layers of the peritoneum, visceral peritoneum, and that is called mesentery. Mesentery, most of the part of the mesentery is the 2 layer of peritoneum because the organ is inside. And the reason for the mesentery we need it because the stabilization. For example, if you are running, the intestine will go otherwise this way, that way, the way you want. So you have to be a little bit anchoring mechanism is there. The liver will fall down. So mesenteries are a very important structure. It stabilizes the thing, but it is a 2 layer by the simple understanding that why the 2 layer because it's going over there. Except the greater omentum has 4 layers. I will come to that little later. Okay, later. The next diagram will tell you that the mesentery, the greater omentum has 4 layers. Why? This is clear to everybody?
Yes.
So no mistake about that. Like if I say this, you people did a very good job in the TBL. I was watching your answer, did very well when we put the omental bursa that behind the stomach. I'll show you again, but you did very well, very well. 74% students could be able to correct and get the correct answer. But what I'm trying to emphasize, lesser omentum, don't memorize it, If you memorize this structure, greater omentum, lesser omentum, and this omentum, that, and you pass the exam, you may get a very good score, but it will not stick to your brain forever. So what I am trying to do, I have a next diagram. This will stay in your mind forever, because if you just follow a little bit. If I take these organs out, this is liver, the stomach, transverse colon, intestine, and the retroperitoneal structure. If the intraperitoneal structure, if I remove it, it will be a balloon. You understand that?
Yes.
This is the first concept. It will be a balloon because these are intraperitoneal. Now how it is covered? This parietal peritoneum, this is the anterior part parietal peritoneum, is covering almost all the part of the liver except a little part over here you can see called the bare area where there is no peritoneum there. But most of the liver is surrounded by the peritoneum. By my drawing itself you can see that. And then it comes to the stomach. That's your lesser omentum. Liver to the stomach, lesser omentum. Now the interesting part, you answered that question when somebody asked, I think Dr. Olina or whoever asked that question most likely. You answered correctly. But you never asked that question. I'm going to explain not today, but the next class I will explain very nicely. Why do we have that little space over here called omental bursa or lesser sac? Why do we have that? There's a reason for that. Otherwise, the entire place is the greater sac. You agree with me?
Yes.
Greater sac, this is all of a sudden there is a sac, there is a balloon, is a partition. Why we need a partition? How did it happen? That you never asked that. And if I ask that question, you cannot answer, I know that. Because the gross anatomy people, they do not have that time to make it happen. That why do we have a lesser omentum? I will explain that when the rotation is coming for the stomach, you know a little bit, the rotation of the stomach, where we have the vagus nerve in the thorax, left and right vagus nerve becomes anterior and posterior. All these things, we'll do that one more time, next class, okay? And there I will explain to you why do we have lesser sac. Within a big balloon, the lesser sac is there, so that's the lesser sac. But for the time being, you memorize, because when you answered correctly, I was observing, I said, how the students could able to answer this difficult question? Because you did the right thing. Anything behind the word was there, I was watching the question. The word was behind the stomach. And you jumped onto that behind the stomach is definitely, you are right, it is the lesser sac, omental bursa. You did the right thing, but you never know why it is behind this stomach. So if you know from the embryology, that will stick to your mind forever. Okay? So anyway, let's finish it. So there's a 2 layers. So this is the mesentery, lesser omentum is the mesentery. Right? Then it comes to the stomach, and from the stomach, It greater momentum starts from the greater curvature. You remember greater curvature. This is the lesser curvature, this is the greater curvature of the stomach. It goes down and then comes back. So the 2 plus 2 becomes 4 layer. This is the only place the greater momentum has 4 layer. Only place where the mesentery is 4 layer, because it's going down and then comes back. Comes back to where? Not to the stomach, but goes back to the transverse colon. Then there is a little mesentery of the transverse mesocolon. Then it is called, circulating around the intestine. And here we call the mesentery. I think the gross anatomy people have emphasized it quite nicely, and you are quite happy with that. So these are our mesentery, 2 layers of the mesentery, most of the places, except this one over there. And then it joins the important part. There are some space over there. You did very well in the exam too. I was looking at the other pouch of Douglas and other thing. But then it joins with the parietal peritoneum. So it goes like, this diagram is also needed tonight, if you really want to get your concept that how it is reflecting. So this is all about peritoneum. Is a piece of cake. I like piece of cake because it's a very nice, sweet, and everything. It's very easy. Isn't it easy?
Yes.
It's difficult?
No.
No. Very good. And the other structures go, and therefore I thought I should end up with the peritoneum. I will continue this. This is just a preamble. This is the beginning, must know information. I have taken also from the book, the peritoneum. What is this one? Is the greater momentum. It's a 4 layer. Now you may think there should be a space in between if you look at my previous diagram, but this space does not exist anymore. It's compressed. 4 layers are compressed like this way. So there's no space. This is called the policeman. You remember that, people have said there's a lot of lymphocytes there and taking care of the infection of the abdomen. Is that okay?
Yes.
Will you remember what I said?
Yes.
If not, then tonight is your night. Then draw these two, 3 diagram. It will be very clear to you. Okay? Now I start the next PowerPoint. That should be number 2. Okay. Now, if I put this slide, you have done the two organs already. The CBP you have done it, and the renal you have done. If I put this slide, just the embryology of the gastrointestinal tract, what does it come to your mind? What does it come to your mind? What are the things you have to learn? So very isolated. So you are not very structured, but when we make the PowerPoint, we think about you, and it has to be structured so that I am not talking about the anal canal first before the stomach. So objectives, we call objectives, right? And the objectives are dissected or structured in such a way that first, always in my mind, that the process, how the GI system is starting, that's the process of development. Yes or no? I talked to you about the cardiovascular system. I talked to you about remember the kidney, about the pronephros. So the process, that's the process of the final kidney. So how it starts, okay? Tell me which week it will start? 4th week, very good. All the organs, they start at 4 weeks, except the heart at 3rd week, and the nervous system starts a little early. Otherwise, most of the organs, you think about any organ, limb development, GI system, and then endocrine system, everything is week 4. So this part is clear to you, week 4, and you should complete by 8 weeks, right? Organogenesis, very good. Then what else do you have to understand when I put this slide? What are the other objectives that you want to do it? Molecular mechanism. Remember, in each block, I put some particular gene responsible for the development. So it's very important for you. If you have to know a couple of genes That is the integral part of the development of this, right? And finally, you must know that why are you learning this? There must be some clinical scenarios. So my last slide will be, today's last slide, will be plenty of diseases that we have to dissect it in such a way that at the end of the GI resource session, that you are able to understand all the diseases. So I'll just list the diseases. I do not expect you to understand anything today. I'm not going to explain anything today. But over the time, those diseases will come, like Baker's diverticulum will come, annular pancreas will be coming, tracheoesophageal fistula will be coming, omphalocele will be coming, gastrocrease will be coming. There is no shortage of the diseases developmental. I'll just name it, but not explaining it. It will be explained over the time. Okay? That's why I do it for all these slides. So let's see the objectives, what they are saying. Let's see the objective. Describe the process. Exactly I said, describe the process. These are the objective, development of the GI tract. List the derivatives of the foregut, midgut, and hindgut. So the entire GI is divided into three parts, which you know already. Foregut, midgut, and the hindgut. Foregut, actually, we start from the pharynx, okay, and then the esophagus, then the stomach, half of the duodenum, not the full duodenum, half of the duodenum, and then you have the liver, pancreas coming from the foregut. Except one structure, spleen, which doesn't come from the endoderm, which comes from the mesoderm, which is a different story. Spleen does not come from any other structure, is a mesodermal structure, spleen. We'll talk about that little. But underlying spleen, that it does not come from the endoderm for the time being. But these are the foregut. Now, which structure I did not tell that comes from the foregut? Let's see, the student should be able to answer that. I indicated the GI system. Which structure I did not tell? One more time, what I'm saying is that foregut has pharynx, foregut has esophagus, stomach, half of the duodenum, and then the liver, obviously, pancreas. And I said the spleen don't include it. But I did not tell one more important structure, which you have done it. What is that structure? Comes from the foregut or the endoderm. I can't hear. Did anybody say lung? Who said lung? I said lung. You agree with that? The lung comes from the endoderm, from the foregut structure? That's what we had tracheoesophageal fistula.
Yes.
Now you cannot say yes right now. Maybe that's the question I have to put it. That why are you forgetting? The question will be, why are you forgetting the lung in relation to the foregut? Because it was an earlier block. Now don't forget the earlier blocks, and it will be integrated block. Lifetime learning it should be. So you understand that your mistake? Foregut. Let's see, we'll come to that very soon. And then the molecular basis, which I was telling you, that each block should have a molecular basis of the development. We do that a little bit. And finally, underline the mechanism responsible for the developmental defects of the GI tract. So all the diseases that are needed, I will explain to that. Okay, but not explanation means understanding. I'll just explain in a way that these are important for you for many weeks to come. Okay, now let's see that points to remember. I'm talking about the process. The primitive gut begins at the fourth week. Did I say that?
Yes.
Okay, very good. The endoderm gives most of the epithelium and glands of the GI, except cranial and the caudal extremity, they come from the ectoderm. Like the last part of the anal canal and the first part of the mouth, like of the lips, these are ectoderm, and after that the endoderm starts, up to the anal canal. Okay, almost to the last part. The muscular tissue, look at this carefully, you answered very nicely. Muscular tissue, connective tissue of the wall of the digestive come from the mesoderm. Which part of the mesoderm? Splanchnic mesoderm. Correct?
Yes.
And finally, the primitive gut is divided into foregut, midgut, and hindgut. And I'm giving you, I'll come to that a little later, the molecular basis, okay? Look at the first thing I wrote it before I forget, lungs. This is the international problem. So if I ask this question, your answer will be international problem. Not only you, everybody does this mistake. Lung means they think it is separated out from the GI system. It's not connected. Lung is also coming from the endoderm. Foregut structure. Yes or no?
Yes.
Yes. Then I said everything: esophagus, stomach, upper part of the duodenum, liver, gallbladder, pancreas, pharyngeal pouches, and what is the embryonic source of spleen? Mesoderm. And I will explain next class, not this class. Explain that next class. Okay? Midgut, lower duodenum, jejunum, ileum, cecum, appendix, ascending colon, and proximal 2/3 of the transverse colon. Have you heard the name transverse colon? Yes, you did. So first part, which is the proximal part, is the 2/3, is coming from the midgut. And this has the developmental origin. And I tell you why the foregut, midgut are placed like this way. Because first the foregut structure comes, then the midgut comes, then the hindgut. It's not the hindgut comes first, before the mouth or the esophagus or the stomach. These are the scenario, and that's why it is supplied by different arteries. The developmental is completely different. Okay, rotation and everything is different. So midgut, you remember lower part of the duodenum or half of the duodenum, jejunum, ileum, cecum, appendix, ascending colon, proximal 2/3 of the transverse colon. Okay? Then comes the hindgut, the last part of the, or the distal 1/3 of the transverse colon, descending colon, sigmoid colon, rectum, upper part of the anal canal. And don't forget that cloaca. Remember that cloaca story? So that is also forming the urogenital system. And we have the block director over here, Professor Faisal. So he will be running the show, and he makes sure that people understand this derivative. And you know it already a little bit, that the cloaca is the endoderm is joined with the rectum, and it is divided into two parts. One is the urogenital sinus and the rectum or the anal canal. We'll go through again, so don't worry. So this is a part of the hindgut. Okay? So these are together, all together is the hindgut story. We will do that in the last lecture. Okay? So one more time, regarding the objectives, you should understand the basic rules of development of any organ. 4th week, how is finishing 8th week, what are the things associated with it, what are the different parts of that foregut, midgut, hindgut, what are the things coming from the foregut, midgut and the hindgut. And now I'm going to explain to you the molecular mechanism, which is very interesting to me, but you have to have a total understanding. I'll be using a couple of genes over here, but don't look at it for the time being. Just listen to me, look at me please. Don't look at this, because you will be disturbed by looking at the number of genes. That is a must know information. Now, what happens is, around 4th week, you have the endoderm already. Endoderm means the tube is already there. But the tube doesn't look like stomach, it doesn't look like intestine, doesn't look like anything. It's just a tube of the epithelium. It's just there. Now all of a sudden, at certain places, and I told you that it is the craniocaudal orientation. First the mouth and then you think about stomach. Think about stomach. In the stomach area, you can calculate that where the stomach would be, and before that there was the esophagus there. So let's start think about the stomach, because it has a little architecture. Esophagus is only tube, not much architecture is there. But the stomach, you cannot draw like this, you have to draw like, isn't it?
Yes.
So that's what I'm giving the example, stomach. So in the stomach area, all of a sudden, there is a concentration of the retinoic acid. You know the retinoic acid is a vitamin A type of thing. So it's a derivative of the retinoic acid. So it is increased all of a sudden. So whenever the retinoic acid concentration is increased, there will be a development of an organ. Now how it will be? Stomach, because of this gene, this is called SOX2 gene, this is a transcription factor, will be triggered. So the triggering factor is retinoic acid. It will express a gene called SOX2 will be expressed and will make the shape like a stomach. The next will be duodenum. Is called the PD is for the pancreaticoduodenal X1. The name of the transcription factor. Then it will be duodenum. The small intestine, again, the retinoic acid will be increased in concentration. That will stimulate the transcription factor. Name will be CDXA, and all of a sudden small intestine will be formed. You got it? So what you have to remember that there are 4 or 5 transcription factors are responsible for the development of each organ that in the GI system. But the triggering factor is retinoic acid. So that's what probably somewhere I read it, I can't remember it. Yeah. The gut tube formation is triggered by the retinoic acid, RA. In the pharynx, RA gradient is established with little or no RA to colon. The RA gradient causes the transcription factors to be expressed in different places. You do not have to know more than this, less than that. So now the interesting part is you are 100% clear. You are 100% clear that why the stomach looks like a stomach is different from the duodenum. Duodenum is a C shape. When you draw that, you cannot put it like a tube. You have to make a C. Letter C is the duodenum. How does it happen? Because of that PDX1 gene is expressed over there. Okay, and therefore, so it slowly, and then finally it comes to the anal canal. Is that okay?
Yes.
And again, I'm saying don't push more than that. Like I told you that in the heart we had 500 genes, and then one student wrote me that I cannot sleep without telling me the 500 genes. They don't go beyond that, beyond 1 or 2. We did couple of genes, but not 500 genes. Here is easy to remember a couple of genes over here in responsible to this. Okay, that leads to, and this is showing you if I put it this photograph, and that's what I draw myself from the textbook, you will not understand anything. If the concentration is coming, that's why it's nice to see this, that what I'm saying is correct over here. But bypass that, go to this one. This is the last slide. I'm going to put it, and I'll be explaining it in my next class, and the next class, and the next class to cover all the diseases. And the question is, why do we have to learn the embryology of the GI tract? Not just because it's a good-looking stomach is there. There are problems. Stomach rotation has a problem, or maybe some congenital hypertrophic, pyloric stenosis is there, or annular pancreas, or these. So I listed lots of diseases over here. You can go through that disease, but you will not understand anything, and which I do not want you to understand anything at this stage. We will be dealing with that. But I'm answering the question that why do we have to learn the embryology of the GI tract? Because of many congenital problems are associated with this. We will dissect it. And very interesting problems are coming up, like omphalocele. A baby is born with the intestine is outside. Somebody is born, I'm talking about somebody means little baby is born, and then there is no anterior abdominal wall. We call gastrococele. The previous one was the omphalocele, etc. The rotation problem, this problem. Everybody knows by now that if you are drawing the GI system, you have to put the transverse colon in front of the duodenum.
Yes.
Right? When you draw it goes like the transverse colon, and the duodenum is put. Sometimes the transverse colon may be behind the duodenum. Why did it happen? You open the abdomen and the transverse colon is behind. You cannot run away from the surgery. You say, oh my God, Dr. Paul, there is a transverse colon behind the duodenum. I cannot do anything. Now this will happen, so you have to know the understanding of the embryology. Okay? With this, I stop it over here. Thank you very much for listening. Good.